So in this video we will talk about penile cancer. Squamous cell carcinoma is the most common variety of penile cancer. It accounts for more than 95% of cases. The mean age of presentation is 55 to 60 years. And the most common mode of presentation is a painless lesion. And the frequency of occurrence of this painless lesion is more in glands than prepuce shaped, and in 30% of cases multiple sites of the penis may be involved. Now coming towards the risk factors for the penile cancer, so these are the following risk factors. The most common and the most important among them is circumcision. Penile cancer is more common in those men who are uncircumcised. The other risk factors are pre-malignant lesions, for example, lichen sclerosis, leukoplakia, or chronic inflammation of the penis, phimosis, tobacco use, human papillomavirus type 16 and 18, and Sorlin in ultraviolet light rays. Coming towards the mode of spread of this cancer, metastasis occur in less than 10% cases when the patient first present to the clinic. The most commonly the cancer spreads to the inguinal lymph nodes, and 50% men present with palpable inguinal lymph nodes. Distant metastasis occur more common to the lungs, followed by liver, bone, and brain. Now coming towards the how we will investigate and how we will approach towards such patients. So we will take a detailed history and physical examination, then biopsy to confirm the diagnosis, and we can do ultrasound, CT abdomen pelvis, and MRI with contrast to know the depth of invasion and spread of metastasis. Coming towards the biopsy, we can done biopsy when there is non-palpable inguinal lymph nodes or when there is palpable inguinal lymph nodes. For non-palpable inguinal lymph nodes, we have two types of biopsy: non-dynamic sentinel node biopsy, and the other one is dynamic sentinel node biopsy. In non-dynamic sentinel node biopsy, there are 50% false negative rates. And in non-dynamic sentinel node biopsy, how we perform it? Actually, the penile cancer most commonly spread into the superficial inguinal lymph nodes, middle group of superficial inguinal lymph nodes. So we assume that it will be cancer will be present in the superficial inguinal lymph nodes. So we biopsy superficial inguinal lymph nodes, middle group. In dynamic sentinel node biopsy, the lymph nodes are also not palpable, but in this case we use a dye like technetium-99, and with the help of gamma rays, then we pick up the sentinel node and take the biopsy. And the false negative rate in the dynamic sentinel node biopsy is less than 15%. And coming towards when the nodes are palpable, then we can take two kinds of biopsy: fine needle aspiration and excision biopsy. Suppose fine needle aspiration comes out negative, then we will definitely go towards the excision biopsy. Now coming towards the staging for the penile cancer, it is most commonly staged according to American Joint Cancer Committee staging system 2017, in which we divide, which is also commonly called TNM staging. So primary tumor TX, when the tumor cannot be assessed; T0, no evidence of tumor; TA, non-invasive localized squamous cell carcinoma; T1 is further divided into either the tumor is in the glands or foreskin or shaft. Suppose the tumor is in the glands, then if the tumor invades lamina propria, it is T1. In foreskin, invades dermis, lamina propria, or dermatosphagia. And in the shaft, The tumor invades connective tissue between the epidermis and corpora regardless of the location. Then the T1 is further divided into T1A and T1B. T1A tumor without lymphovascular invasion or perineural invasion and is not high grade. That is, it is not grade 3 or sarcomatoid type. And T1 is actually the opposite of T1A. T1B is actually the opposite of T1A. Means in T1B we will have lymphovascular invasion or perineural invasion, or there will be tumor will be high grade like grade 3 or sarcomatoid. Then coming towards the T2, the tumor invades into the corpora spongiosum, either glands or ventral shaped, with or without urethral invasion. Please do remember it. In T2 involves corpora spongiosum, while T3 involves corpora cavernosum, with or without urethral involvement. And T4 is when the tumor invades into the adjacent structures, that is scrotum, prostate, pubic bone. Now coming towards the regional lymph nodes, the regional lymph nodes are staged like a clinical staging and a pathological staging. So in clinical stage NX means tumor cannot be assessed, N0 means no evidence of tumor, CN1 means palpable mobile unilateral inguinal lymph nodes, CN2 two or more than two palpable mobile unilateral inguinal nodes or bilateral inguinal lymph nodes. And N3 is when the palpable fixed inguinal lymph nodes or unilateral bilateral pelvic lymph nodes lymphadenopathy are present. Then there is the regional lymph node pathological staging, which is done after biopsy or surgical specimen. Like P in X tumor cannot be assessed, P in not no tumor present, P in 1 equal to or less than 2 unilateral inguinal mets, in 2 3 or more than 3 unilateral inguinal metastasis or bilateral metastasis, no extranodal extension. And P in 3 is extranodal extension of lymph node metastasis or pelvic lymph node metastasis. Then we have a distant metastasis, M0 no distant metastasis present, and M1 distant metastasis present. There are pathological variants of squamous cell carcinoma as well. For example, classic, which is also called usual variant, is the most common variant, varicose, papillary variants, basaloid and warty variants, and sarcomatoid. Basaloid and warty variants are commonly associated with human papillomavirus infection, and sarcomatoid have poor prognosis. Mean survival is less than 1 year. Treatment is the goal of treatment was initially the recommended free tumor margin was initially 2 cm, but according to new guidelines it should be 5 mm. Then the treatment option we have penectomy or penile sparing surgeries. In penectomy we can go for partial penectomy or total penectomy. So in partial penectomy we will do partial penectomy only when the tumor is confined to the glands, prefuse or distal shaft. And in this partial penectomy we have to at least 2 to 3 cm penile length space out for sexual activity, and so that patient can avoid as well in erect position. And with partial penectomy there is 4% local recurrence rate. Now coming towards the total penectomy should be done when there is invasive tumors involving the proximal shaft. In total penectomy we remove all the penis distal to the pubic bone in order to achieve a negative margin. And after total penectomy we do perineal urethrotomy so that the patient can avoid in sitting position. And after doing perineal urethrotomy 10% stenosis of the new meatus occur, and to avoid this stenosis we do speculation of meatus या new urethra. Then we have penile sparing therapy as well. And for the before embarking on penile sparing therapy, we must do biopsy first to confirm the diagnosis and to know about the depth of invasion. And this penile sparing therapy is only indicated when we have CIS or TA or T1 tumors. Options for penile sparing therapy include circumcision, wedge resection, Mohs surgery. It is indicated when the tumor is less than 1 centimeter in size and there are 30% local recurrence rate. Laser ablation or laser excision, glands resurfacing, topical therapy in the form of 5-fluorouracil or imiquimod. It has 50% recurrence rate. And radiation therapy. Radiation is mainly reserved for stage T1 to T3 tumors which are less than 4 centimeter in size. Now we have some important points that everyone should remember at the end of this lecture. Number one is, suppose a male have penile cancer and so his female sexual partner is not at the increased risk of cervical cancer. Female sexual partners or patients with penile cancer do not have a high risk of cervical cancer. Circumcision in newborn virtually eliminate the risk of penile carcinoma. Circumcision do not protect against carcinoma in situ. Men circumcised after puberty have same risk of penile squamous cell carcinoma as non-circumcised. Smegma is not a carcinogen and do not increase the risk of squamous cell carcinoma of the penis. Circumcision should be performed before radiation therapy to prevent radiation-induced phimosis. And the other most important point is men with non-palpable inguinal lymph node at presentation, 25% among them will have inguinal lymph node metastasis. In next lecture, we will discuss the inguinal and pelvic lymph node dissection because inguinal and pelvic lymph node dissection is important for the treatment of penile cancer. Thank you very much.